We're going to do a pressure wash of a person's pleural space. Now, saline lavage is very common, especially in developing countries, and the most common way of doing it is to put two chest tubes in a patient, and one by gravity, you are having the saline solution come in and come out of the other tube. Now, that is like waiting for the rain to clean your house. Okay, so the rain drops on your house and it looks clean, but it's actually not cleaned up unless you pressure wash it with a jet, because you are trying to take out a layer of pus and fibrin that is surrounding the lungs of your patient. You are trying to break adhesions. Now, when a surgeon goes in, he's not just bathing the thing in fluid and just letting gravity do the job. They're actually going and removing the adhesions and peeling off stuff. So that thing has to be under pressure. The great thing about doing a saline lavage is that if you have a complicated effusion, the first thing you do is put in a chest tube and drain it out manually. You have to drain it out manually because you can put in more pressure, more negative pressure with the manual drainage than any other suction. Once you have done that, you do a chest x-ray. And if the chest x-ray does not show significant resolution and lung expansion, you don't do TPA the same day because it's costly and you want to see what happens overnight, but you can wash the patient the same day because there is no harm and there might be benefit. Now, the second way of doing it, because I don't like this two chest tubes, I don't like putting two chest tubes in patients when I can get away with one, is to instill saline and then take it out. Instill saline and then take it out through one chest tube. When we did that, we felt that more saline goes in than comes out. But with the vigorous pressure wash technique that I'm going to show you, you never allow the fluid column to break. It's an in and out technique, just like you are doing a mouthwash. Now, I could fill my mouth with mouthwash and then just let it dribble. Or I could take a smaller amount of mouthwash and vigorously move it around. And I think that is more effective in cleaning. So small amounts vigorously moved, okay? The third thing is, should I do a TPA first or a Dornese or the saline lavage first? Now, in my mind, if you have a very dirty utensil, you can do two things. Either you can scrape stuff off and then use the soap, or you can put it in soap and water and then scrape stuff off. And there is no right or wrong here. But I think that if I'm doing a vigorous lavage and there is bleeding, I can say, okay, fine, I'm not going to do TPA Dornese today. I've not seen bleeding, but in my mind, just in case. On the other hand, if I first do TPA Dornese and then do a vigorous lavage, I might cause bleeding, and I don't want to do that. The second thing is that in my mind, a inexpensive vigorous lavage is taking out stuff, making it easier, making a less burden for the TPA Dornese to work on. On the other hand, people could say that why not use TPA Dornese, make things loose, and then use the vigorous lavage to take it out. But that is such an expensive way to do things. You always use the water first and then your special Dawn detergent later, okay? Thank you so much. We'll show you the technique. It is a simple sterile solution of 1000 ml of 0.9 sodium chloride, in which we have put in a normal 10% povidone iodine solution. We have done 10 cc's of this in 1000, so that makes a 0.1% povidone iodine solution. This is a sterile cup that we have just opened. And so what will happen is that in order to keep it all sterile, I will touch this, but I will never touch the tip of my syringe. So I'll just draw it up like that, and so you know that the sterility is being maintained, and as it is, it's going to be a povidone iodine solution, so it is meant to be sterile. So the first time, in order to make sure the patient does not have any pain, I'm going to go slow. And the patient is going to tell me if there is any pain associated with this. Any pain, hon?
Nope.
Okay. So now that there is no pain, I am going to make it vigorous. And as you can see, there are gas bubbles that are coming out because of the fact that the patient has air loculated. in her pus. And also you can see the color change, and that is me taking the pus out, and it is deliberately very vigorous. So I keep doing this like I'm washing a dish, and you know you have to throw the water out once the water becomes bad, and I just keep doing it again and again till I'm done with the whole solution. Let me show you this. As you can see, I've never touched the tip of my syringe. So I just used to, and I don't touch the container. I have made the chest tube so that this always remains on top. I have cleaned it, and always the technique is absolutely sterile because I'm not touching the parts that are contacting each other. So some of the color change will be because you are vigorously frothing it up. It will turn brown. But it's the debris and the cloud of pus that you are going to look at. So this is the last one that I have lavaged, and you can see, despite doing the same thing, the color is actually the color of your fluid. So there was a big difference between the first one and this one. Thank you so much.